Good morning. It is now February 8th, right?
Yes.
February 8th. Hold the head straight, please. We're broadcasting live from the Surgery Center of Vieira and Deuk Spine Institute. Shot. Our patient has a really bad set of disc herniations in her neck. She's got 4 of them that are symptomatic. Shot. AP. And there's one of them is C2-C4, which is extremely unusual. We never see that. I've done one of those in my entire career. Shot. And she's got one. All right, lateral. So in 17 years of doing this surgery, I've done maybe 1 or 2 2-3s. Shot. Here we go. Shot. AP. Quick. Feel good. Yeah. Shot. Quick shot. I want to make sure the needle is in the center. We're off to the side. Shot. Yeah, which I think we're a little bit off to the side. Back to a lateral. No worries. I'm going to try to come back towards you. Shot. Shot. AP. Quick. Shot. That looks good right there. Now lateral. Yeah. Shot. Yeah. I think we're good. Shot. All right. I'm going to go in. Shot. That's nice. All right, no, not yet. Let's do Coker. Let's verify we're midline. So what I was getting at, this patient has an unusual situation. Number one, she has 4 herniated discs that all 4 need to be fixed. Most people have 1 or 2. The average is 2.2. Perfect. The second thing about her is that she has a C2-C4 herniation. C2-C4, I mean, you'll see 1 in every 200 patients. It's extremely rare, C2-C4. And we're going to treat that today. I still remember the name of the last patient that had a C2-C4. 10 years ago? Yep, 10 years ago. I know his name. You don't forget things like that because C2-C4 is so rare to fix. Never. This patient, 2, 3, 4, 5, 6, 7. You agree? We'll start at 6, 7. Shot. AP. She has a connective tissue disorder. I think it's Ehlers-Danlos. Wait.
Yes, sir.
Yeah. All right. Go ahead. That's it right there. Fine. Thanks. Lateral. She has Ehlers-Danlos, which is a connective tissue disorder. Shot. And as a result of that, she has some abnormal shot disc herniations. Shot. AP. So she has 4 herniated discs. We're going to fix all 4 today. And they're pushing on her spinal cord. All right, good. So that's 3, 4, 4, 5, 5, 6. Let's go back. Lateral. 2, 3, 4, 5, 6, 7. You agree? 2. That's 2. There's 2, 3, 4, 5, 6, 7. We're doing 6, 7, and 5, 6 with 1 needle. We're doing 3, 4, and 2, 3 with the other. So we're good. All right, at this point, we're going to start with the bottom discs, the 5, 6, and 6, 7 shot. And I'm going to inject a little bit of dye so you guys can visualize the herniation with the tear. And why are we treating her? 2 reasons. She has pain from the herniations in her neck, head, shoulders, arms, and she has myelopathy. Shot. Shot. There we go. All right, there's the tear. You see it? Jordan, show us the tear. That's the tear in the back of the disc at C6-7. The tear is actually lower. It's the right there. You see it? There it is. Yes, that's the tear. And then the dye has leaked out, and that's why you're seeing a weird shadowing. All right, Luis wants me to do the discogram at 3/4. Sean? So let's do it. Will you bring your collimator down a little bit? I think you're a little wide, too far anterior. Shot? All right, there's the tear and herniation at 3/4. I'm going to do a little bit more. Shot? Perfect. Henry.
Yes, sir.
Let's show the audience, why do people get so much pain from a herniated disc in their neck? What's the mechanism? Dr. Deuk, returning you back to the operating room. I'm Dr. Deuk Majin. If you joined us late, you just saw on our video that, and Jordan, show us this x-ray. Henry, take a look at this. First, I'm going to show you C3-4 AP view. Look at the tears on both sides. Look at the dye. It's the dark stuff. It's dark color leaking out around the nerve on her left. Show that. Yes. That's the nerve root. So folks, there's 3 reasons to get surgery on your disc in your neck. Number 1, neck pain that doesn't go away, and it's coming from the disc. Number 2, radiculopathy, which is a pinched or irritated nerve root that causes arm weakness, numbness, tingling, or pain. Number 3, myelopathy, which is spinal cord abnormal function or dysfunction as a result of spinal cord compression or inflammation. So those are the 3 reasons to do surgery on someone's disc in their neck. Now, what are the diagnoses that cause that? Number 1, herniated disc, bulging disc, ruptured disc, slipped disc, protruded disc, extruded disc. Those are all reasons to do it, okay? And, but just having a ruptured disc by itself is not a reason to do surgery. Hold on. Yeah, that's fine. By the way, take a look at that x-ray there. You can see the tip of the dilator is sitting in the tear. Show us the tip. Remember, we're at C6-7. We're starting at C6-7. The tip of the dilator is sitting in the tear. And now I'm going to bring the tube down over the dilator. I'm keeping an eye on the needle at C3-4 the whole time. I don't want it moving. Folks, the entire surgery is being done through these 2 tiny little incisions. By the way, look at the blood drop right there. We got half a drop of blood. That's our blood loss so far for the surgery, okay? So this surgery you're watching is the future of spine surgery. It is the future. Unfortunately, most spine surgeons don't know how to do it. They're never going to learn how to do it. They're stuck doing fusions and artificial discs. Keep an eye on that. And they make a lot of money. That's perfect. Thank you. They make a lot of money doing fusions and artificial discs. Meanwhile, you, the patient, suffers because you get complications from those invasive surgeries. You get scar tissue, muscle damage, nerve damage, fascia damage. The disc is being taken out and fused, so you're losing your movement. All those are problems associated with invasive surgery like fusion. With our surgery, there's no muscle damage. We're spreading the fibers apart. When we leave at the end of the surgery, the muscle will be normal, the fascia will be normal, there'll be no scar tissue. The only thing we're damaging, the only thing, is a cut in the skin, and that's 4 millimeters. Yep, so getting back, be careful with this one. Getting back, Henry, I know we've got some questions, and
Yes.
I'll take those questions, but I want to make sure everybody's clear. This surgery replaces ACDF, artificial disc, and it goes beyond, because those two surgeries are done for treatment of radiculopathy and myelopathy for stenosis, but they don't treat inflammatory problems like neck pain, cervicogenic headache, cervical brachial syndrome, and cervical radiculitis. This procedure does. So this goes beyond an ACDF and does even more. This is the future. There's no metal, there's no fusion, there's no hospitalization, there's no complications to date with this surgery in 17 years. That fiber right there at 12 o'clock is the laser fiber. It is 0.5 millimeters thick. Look how precise the laser is. There's no surgical tool as precise as the laser. Scalpels, rongeurs, everything used in normal neurosurgery, orthopedic spine surgery, much bigger, much bulkier, much more risky and dangerous for the patient. Having a laser that has 0.1 millimeter, tenth of a millimeter precision, you can't do better than that, folks. All right, we're a little bit overexposed. Let's turn the light down a smidge, maybe 1 or 2 clicks, and that should be good. Thanks. You see the gold color? That is calcium. The reason there's calcium, there shouldn't be calcium here. The reason it's here is what we call dystrophic calcification. It's an abnormal calcification of an area of inflammation. And it happens because there's inflammation going on for a long time. You see that gold color? All right. Let's take some questions while we remove these herniations.
This question comes from Samir on YouTube.
Hello, Samir. There's a herniation right there, folks. Right there. You guys see it?
Yes, we do.
Sitting in the tube. Now, notice the edges are like, what's the word? Fuzzy, frilly. That's because it's a new herniation. Old herniations are scarred. All right, go ahead, Samir.
Samir asked, Doc, any risk of general anesthesia for cervical?
Is there any risk of general anesthesia for cervical? The answer is anytime you do anesthesia, there's a risk. However, if you have a really good anesthesiologist and really good equipment and a really good nurses and a really good team, the risk is almost zero. So the answer is, in my opinion, it's virtually zero. Now, it's not 100% zero because there are some really bad anesthesiologists out there. There's really bad surgeons too. But our anesthesiologist is as good as they come. You cannot do better. Deuk Spine only has the best. So I would say your risk of anesthesia is extremely low. Less than 1 in 500. Go ahead, next question.
At this moment, no current questions.
All right, well, let's show everybody. You see the tear down here that I'm cleaning with the laser? There's a herniation. That is the annular tear, folks. And by cleaning it with the laser, that's going to allow the body to heal. The body cannot heal this tear unless we clean it first. This is the only surgery in the world that cleans the tear. We pioneered it here at Deuk Spine. Watch the needle. And we're the first to do it. We are the first to publish it. It's called an annular debridement. And it's the most important part of this surgery. Cleaning up the tear. You guys see the posterior ligament down there? Just below where I'm operating? Just get past the gold and you see it right there. That's the PLL, posterior longitudinal ligament. So far, everything's going well. She's stable with the anesthesia. She's sleeping nicely, and I am removing her herniations. These are at the back of her disc, folks. We're literally looking at the very back of the disc. We're not looking at the front. We're not looking at the middle. We're looking at the back. People ask me, is this the same as a laser discectomy? No. A laser discectomy, percutaneous laser disc decompression, PLDD, is basically where they stick a needle in the disc, just like I did in the beginning, and then they put that blue fiber down the needle and just zap it a few times, and they're done. We're not doing that. We're actually seeing with our eyes the herniation and the annular tear. And I'm targeting the laser energy arthroscopically to the part of the disc that needs it. That's the difference. With the PLDD, there's no targeting, there's no navigating with your vision. It's all done with X-ray, and it doesn't really do anything. That's why Medicare stopped paying for that procedure many years ago. Literally stopped paying. There's more herniation. Now, I don't use insurance company payments as a guide to what to do to treat patients. I always choose what is the best for the patient. That's going to be my top recommendation. You got that needle? Yes, I always think, what would I do for myself? Which treatment would I want? What would I do for my wife? And by the way, I do love my wife. What would I do for my children? What would I do for me? And this is the surgery. The problem is I'm the only one who does it right now. So we need to change that. We need to get so more doctors do it. And doctors will not do this procedure as long as the insurance companies don't pay for it every single time. Doctors do not know how to treat patients unless the insurance pays. They want payment. And we've been doing this for many years, and a lot of times the insurance doesn't pay. So we have to still be able to do it and recommend it. But many doctors won't even consider it unless they're going to get paid for what they do. I've done, almost 500 for free. And I had to pay for those surgeries. When I say free, I mean free for the patient, not free for me. Why am I getting, how's our irrigation? It's a little cloudy here. Are we doing all right? By the way, the patients we did, today is Thursday, we did surgery on Tuesday. Those patients were doing phenomenal when I saw them yesterday. No problems. Any questions, Henry?
At this moment, no current questions.
All right. You can see the tear of the annulus, the white thing right there. You notice I'm cleaning it, getting rid of the blue stuff, which is the herniation. So far we've had maybe one drop of blood loss, one drop. This is a bloodless surgery. We don't lose blood. We don't bleed patients like other types of invasive surgery do. Any questions?
No current questions.
Now she is a Florida lady, right? She's from Florida. We have a lot of people that travel from around the world to come to Deuk Spine for surgery, but she's a Florida lady. She comes from about 4 hours away. She did not want fusion on her neck, and she has, as I said earlier, a connective tissue disease or disorder known as Ehlers-Danlos syndrome. And people with Ehlers-Danlos, they don't make normal connective tissues. They're weak. They have weak connective tissue. And this is all scar tissue, by the way. I just removed a bunch of scar tissue to help her heal better. All right, any questions?
No current questions.
Perfect. Well, there's the nerve in the foramen right down there. I don't see any more herniation, maybe a tiny bit right here. We're getting rid of it, and we should be done with this disc in about 2 minutes. By the way, people ask, is the laser safe? Yes, if it's safe. Now, you can ask yourself, is a gun safe? A gun is safe as long as the person using it, knows what they're doing, right? A gun may not be safe in my hands because I'm not a gun person, but somebody like a soldier who knows how to use the gun and is trained on it, it's safe. They're not going to accidentally shoot you or anybody else. But with the laser, again, you have to be trained. It's like a, it could be dangerous if you don't know what you're doing, but so could a scalpel, right? So if I take a scalpel, I can hurt people with a scalpel if I don't know what I'm doing with the scalpel. So I get this question a lot, is the laser safe? Absolutely, it's safe as long as it's in the right hands. The other question I get is ultrasonic surgery better or is laser surgery better? 100% laser surgery is better. We're able to do ultrasonic surgery at Deuk Spine. We choose not to do it because it's just a gimmick. It doesn't work. We don't do gimmick surgeries here. We do surgeries that work. We don't do robotic surgery because it's totally a gimmick. We don't do ultrasonic surgery that often, even though we can. It's a gimmick. We could do robotic surgery if we wanted to. We choose not to. It doesn't add any value to the surgery. It doesn't make the surgery better. There is a big old herniation right there. Too big to come out of the tube, actually. On its own, I'm going to have to reach down with my grabber and see if I can pull it out. Any questions?
No current questions.
So, have we played both educational videos?
Just the first one, not the
Let's
second.
play the second one. What does this surgery actually do?
Of course.
We're just about done here. Another, I don't know, minute to go. Okay, welcome back. Now you understand how this procedure works. We go through your disc. We don't hurt it in any way. We use a tube. That's the little 4mm tube. And then we use a laser to repair your disc by removing all the junk that's out there causing pain. We're done.
2 on, please. Yep, scope out. Thank you.
We're done with one disc, by the way, not all 4. We're supposed to fix 4 discs. So I'm gonna use some antibiotics, and we've never had an infection with this surgery, but We don't want one either. Now, I did have some patients who didn't know they were allergic to iodine, and they ended up with some inflammation from the iodine. So we use a much lower concentration of iodine now, and haven't had those problems. Okay, let's get the fluoroscope in. So we have two types of scope. We have a fluoroscope, which is an X-ray scope. We have an optical scope with a camera, which is called an endoscope. We use sometimes a microscope if we're doing an ACDF. Let's go, Jordan. Shot. All right, perfect. So we're going to come out of the 6-7 disc, and I'm going to move up to the 5-6. Shot. You'll see the tube coming backwards. Meanwhile, whoops, I think I disconnected. Meanwhile, the dilator will stay in position. The dilator will stay. The tube comes out. Shot. Now we're going to do something that we pioneered here at Deuk Spine once again. It's called the Deuk Spine Shuffle, or slide I should call it. Sorry, slide. The shuffle is for the DPR. All right, we're going to move up a disc. 2, 3, 4. Ooh, look at that C3-4 needle, Luis. Almost came out. Shot. Yeah, we don't want that coming out. Nope. Shot. I'm going to slide right up the spine. You keep an eye on that 3-4 needle. All right, I'm outside the disc now. I'm right in front of the spine. I'm going to move up to number 5-6. Shot. And shot. And then let's get, I feel like I'm on the side a little bit. Let's get an AP. Quick, right now. Shot. All right, we are to the side. Shot. Need to be in the middle. Lateral. No, it's fine. I'm over the spinous process. By the way, bloodless surgery, folks. We lost all of our blood during the injection of the numbing medicine. Come on, mallet. Shot. I'm going to be entering the next disc through the annulus. Remember, the dilator will spread the fibers open. Go ahead. The dilator is like a pencil tip. When you push it through the annular fibers, it doesn't cut them, it spreads them. Shot. Shot. All right. Go ahead. If you feel you can do it. Any questions?
No current questions.
I'm going to inject some dye and try to do a discogram here. Shot. There we go. We did it. All right, we got our second drop of blood. By the way, you need 20 drops of blood to make a mill. Guys, see the tear? Show us the tear, Jordan. We're going to slide this dilator right into the tear. That's what we're here to fix. Shot. Shot. All right, now that I'm inside the tear, I can repair it. That's the basis of the Deuk laser disc repair. We're repairing the annular tear. We're debriding it. Shot. Got to keep an eye on the dilator. It might slide back. It gets pressurized by the disc. Some people's herniated discs have so much inflammation going on that they will literally push the dilator out of the disc. I've seen it happen several times. See that? There's another one. It's literally pushing the dilator backwards. Huh? Yeah, it should be good. Go ahead. Thanks. Yeah, thank you. Let's check 3-4 shot. 3-4 looks good. All right. Any questions?
No current questions.
So had this patient gone anywhere else, they would have had a 7-level fusion. The surgeons would have fused them from C2 all the way down to T2. That's actually 8-level fusion. But not at Deuk Spine. We're able to fix these discs and not fuse her neck. It's going to look like she had an encounter with a vampire when we're done. But I assure you, we don't have vampires here.
That's when you increase your risk of anesthesia, duration of time, and a large surgery, big incision like that.
Yeah.
People are asking about risk of anesthesia. That's when it becomes, the risk is elevated.
We do a screening for vampires on our employment application. And we do a federal background check, make sure we're not hiring vampires. All right, there's some calcification, bone spurs, people call them. Thanks. Flip it. Thank you. We're back, right, Henry?
Of course, yeah. No current questions, but we do have a comment from George on YouTube.
Sure.
George said, "I'm learning soon. I will be able to do it. If you need, I can do it."
I love it, George. Thanks. Yeah, this is unfortunately not one of those things that you can just kind of watch a YouTube video and go out and do. So please don't do that. There's the spinal cord right down there. You guys see it? There's a herniation I just cleaned with the laser. See the tear? Oh yeah, there's a herniation.
We saw that for sure.
Yeah, that was an easy one to see. Oh my. Alrighty then. Well, so far everything is going really well. I need another 5 minutes on this disc, then I'll move up to 3-4. There's another piece of herniation. Now we call these reverse herniation because they are a herniation, but they're sitting out there in the, on top of the spinal cord, and then we start to remove some of the scar tissue holding them there, and they end up coming back towards us. Look at the 1/10 of a millimeter precision, 1/10 of a millimeter. Remember, the laser fiber is 500 nanometers. So it's 1/2 a millimeter. Look at the scar tissue here. You see that? Now look down there. You see that little hole right by the tip, to the right of the tip? Right here? That's a tear in the PLL. That's where the herniation escaped, and it's up against the spinal cord. We've already taken out a few pieces. I'm going to have to go down there and take a look. There's a bone spur, the gold color stuff. We're going to have to open the PLL just a little bit. God, it's beautiful. To my right is the end plate. To my left is the end plate of C5. There's another herniation. That's a subligamentous herniation. It was not in the epidural space. There's another one, but these herniations are the most common, and they're very symptomatic. They cause a lot of inflammation. Oh, there's another one. These are all subligamentous, meaning they're within the posterior longitudinal ligament. Oh, there's a big herniation here. Wonderful stuff. Oh my. Herniation after herniation after herniation. Oh, there's a biggie. There's a biggie. Look at that big piece of meat. That's a big herniation. Man, she's got a lot. Now, she asked me, do my herniations look any different than anybody else's? And I said, no. Honestly, they don't. They're just prettier, maybe. Well, I think I got it there. All right. Any questions?
At this moment, no current questions.
Okay, we're making really good progress on disc number 2. 2 out of 4. That thing is just too big to get out, so I'm going to have to cut it down with the laser. When I say thing, I mean the herniation. That herniation is too big. I apologize. Sometimes I give you guys some operating room lingo, And I forget that some of you haven't been here enough to know my lingo. This is a herniation right here. Now the gold color stuff is osteophyte, bone spur. Look at the dura down there. You guys see it through that hole, the tear in the PLL? All right, it's pretty damn cool. You don't get to see this often. This woman really blew that disc herniation out. Those are PLL fibers right there, running left to right, which is up to down. And below that is the spinal cord. You guys see the spinal cord down there? That's the spinal cord right there. We don't want to damage that. Now I could still see there's some herniation there, right? You guys see it under there? So I'm going to have to open the PLL. This is where the laser becomes the most precise instrument in medicine. There's nothing more precise than the laser. This laser has a precision with the way we use it of 0.1 millimeter. There is only one thing more precise, and that's molecular genetic engineering, chemicals. But chemicals aren't really surgery. Now, some people would say, oh yeah, well, if you splicing genes and you're adding new genetic code to people, which I guess these new COVID vaccines are, right? They're altering the genetics of people. So if you start cutting DNA, then technically you're doing surgery, aren't you? You're cutting. I mean, after all, that's what surgery is, cutting and sewing. So if you're cutting genes out and inserting new genes in a patient, then that becomes a molecular surgery, molecular level surgery. That is the most minimally invasive surgery there is. But of real surgery, that's really not surgery, right? I mean, we don't consider delivering drugs to a patient surgery, but I'm just saying, technically you could consider it surgery because you're altering, you're cutting out DNA and you're putting in new DNA. But with real surgery, like what we're doing, making an incision and operating in an operating room, this is the most precise tool in all of medicine, the laser. And the doctors that bash it on the internet, they write these Google articles or try to tell their patients, oh, it's dangerous. They are deadly afraid of the laser because they realize they don't know how to do it and they're protecting their business. Let's face it, these doctors, all they want is to make money. And so they're recommending these barbaric surgeries like fusion to patients, and their level of precision is not 0.1 millimeter. Ours is. So they know the laser is extremely precise, that it can remove bone spurs, it could treat spinal stenosis, it could treat herniated discs, it could treat bulging discs, ruptured discs, neck pain, back pain, thoracic pain. They know the laser can do far more than what they're capable of doing, but so they're scared of it. So they badmouth it. Now, I am a spine surgeon. I do all surgeries. So I can badmouth the scalpel all day long because I use a scalpel. I can badmouth fusion because I do fusions. I've done 1,000 neck fusions. I could badmouth T-lift because I've done T-lift, A-lift, P-lift, X-lift. All of those surgeries I've done many times in my career of 26 years as a neurosurgeon. Trained at the top neurosurgery training program in the United States at the time. So I am very well trained to do all of those procedures, yet we don't do them because this is far better for the patient. Now we are going to be doing a T-lift next week, right? Or is it the week after? Sorry, in 2 weeks. So if you want to see a fusion, we have a patient who is not a candidate for the DLDR, and she's going to have a T-lift by me. Our T-lifts are outpatient. It takes me an hour a level. She's doing a 1 level. And the reason why she's not a candidate, folks, because I know some of you are starting to ask, the reason she's not a candidate, she has an artificial disc. And guess what the artificial disc did? It popped out. Like I warned you. All the time I warn you guys, don't get artificial discs. They pop out. Hers is popping out, not by me. I didn't do it. Somebody else did. But she wants me to fix it. And unfortunately, the fix, I'm almost done here, is to fuse her. And so we're going to be going in and doing a fusion. That's going to be in 2 weeks. I love it. Huh? No, we're not taking the disc out. To take the disc out, we have to go through the belly. That's too risky, and it's unnecessary, in my opinion. I don't just do surgery because I like doing it. I do surgery because it's necessary for the patient. We're not taking the artificial disc out. We're going to leave it where it is. It's halfway. It's not even halfway out of the disc. It's probably a quarter. And with that, you can leave it where it is. It's far more dangerous for the patient to try to get it out. Huh? Oh, no case. No. We're just doing posterior. Yeah, you're right. It'll be a quickie. Any questions? Gosh, we're done here. Oh, yeah, look at that. I just love cleaning out these foramen. It's just magical. We're done. That's 5-6. We're finished. There's no more herniation. And the disc will now heal because we cleaned out the herniation. We cleaned up the tear. Any questions, Henry?
At this moment, no current questions.
Oh my gosh, do people just know everything?
I guess so, yeah.
Do we have any people watching?
Of course, we have a good amount of viewers.
That's good.
I think
All right, we're done with number 5 and number 6 in the cervical spine. We've repaired both discs. Next, we're going to move up to 3-4 and then 2-3. I told her before surgery, I said to her, there's a 10% chance I won't be able to get the 2-3 disc, you know, because 2-3 is so hard to get to. But to be honest with you, her neck is really long. It's actually a nice shape for getting the 2-3 disc treated. But like I said to you before, I've only treated 2 or 3 patients in my career with C2-3 herniation because it's rare. But in her case, she has it, and it's bad. I already gave num. Oh boy. Get a shot. All right, so the needle came back a little bit again. Go ahead. Just be careful not to pull it back. Now we're going to move up to the number 2-3 and 3-4 discs. How's she doing, Dr. B? All right, Louise, hold pressure here. Any questions, Shot?
Yes, yay, we got another question. This comes from dissemination_14 on YouTube, asking, does Horizon Blue Cross Blue Shield work with you guys normally for the DLDR?
We have had Blue Cross Blue Shield pay. We don't know if an insurance is going to pay typically until after surgery. So, but what you have to do as a patient is you're going to have a out-of-pocket shot payment that you'll pay ahead. And if your insurance pays the whole bill, 100%, you're going to get it back. Shot. But they got to pay the full charge. The problem is we don't have a contract with Blue Cross. I do as a surgeon, but our surgery center does not. Jordan, is that it? What? What? Yeah. So without a contract, and even with a contract, insurance companies often will lie to the provider and say we're paying, but they don't pay. So if you think about it, in the best case scenario, they pay. In the worst case scenario, they don't pay. And we cannot operate a business paying for people's surgery. So there has to be some money paid up front so that we can cover some of our costs. And then we run the gauntlet and hope that Blue Cross will pay, or any insurance. But even when we have a contract with an insurance company, sometimes they don't pay. I tell this story. We had a patient who the insurance company signed the contract for DLDR, and we did the surgery, we billed them, and they never paid. And we called them and said, why didn't you pay? And you guys signed the contract. They said, yeah, we signed the contract just to get you to do the surgery, but we were never going to pay it. You know, I mean, of course, we hired a lawyer, and we threatened to sue them, and they paid eventually. But it took a lot of phone calls. Let's get a AP. So to answer your question, we expect Blue Cross to pay. We've had them pay before, but it doesn't mean they're going to pay. And we can't take the risk of your insurance not paying. You have to take, this not flex. Yeah. We can't take the risk of your insurance not paying, because then basically we're paying for all the supplies, all the staff, all the equipment. We're paying for your surgery, and we don't run a charity. I mean, we get no money from anybody. So the only person that would pay for your surgery would be me. And I can't afford to pay for everybody's surgeries out of my pocket. That's not what we do here. We'll go out of business overnight. So yeah, until we get the insurances to lock into a contract, people have to pay some money up front. Shot? Get all the way down. All right, let's keep an eye on that. Shot. 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 Shot.
Yeah, it's good, but you want to do an inline track?
Huh?
Inline?
Do a little bit of inline. Shot.
Coming right now. Thank you.
Shot. Shot. Magic. Shot. Oh. All right, the dilator went back a little bit. Shot. Yeah. This disc is under a lot of pressure, I can already tell you. Shot. All right. Huh? Yeah. Oh, no, that's not good. All right. Hopefully it's off to the side. Yeah. We're off to the foramen, which makes it, should be okay. All right. Yeah, this thing is unfortunately not cooperating. All right, let's try again. Shot. See, it just keeps coming out and going in. So hold on. Take that up. We don't want to advance with the just the tube, because then you're going to end up biopsying the disc. Yeah, it just keeps moving. It's very, very odd. Now this may be related to a disease. Okay?
Yeah.
Just have to be really careful here. We're off to the side, so we should be okay. All right, let's see that. That's as good as I'm going to get it. All right. Let's see where we are here. Tube is in good position. You could see the original levels, 5, 6, 6, 7, look good. No problem there. No bleeding. All right, now we got a pretty bad herniation here at 3, 4, and it's pushing on her spinal cord. The same thing at 2, 3. So we need to try to get in and get out as much of this as we can. There's the foramen. Look at all this herniation here. And this has gone right through her PLL, just like the last one. PLL is the posterior longitudinal ligament. So normally there's the disc ends, and then you have the posterior longitudinal ligament behind the disc. Hers has been blown wide open by the herniation. You look at all this, just it's sitting right on top of the spinal cord. So if the disc herniation does not go through the PLL, posterior longitudinal ligament, we call it contained. If it does, then it's non-contained. In her case, she has 2 giant herniations up here at 2, 3, and 3, 4. And they are not contained. They're pushing on the spinal cord and the nerves. Look at that herniation right there. You guys see that? That was sitting in the foramen right on her nerves.
Yes, we do. No current questions, but we do have a comment from Dissemination once more on YouTube.
Sure.
They said, high likelihood I will personally need a cervical disc surgery in the near future. I am 25 years old, and so getting a minimally invasive surgery is extremely important to me. I found you guys, and you gave me hope, but I might need a discectomy locally. I live in New Jersey, depending on what my insurance will cover.
Understood. Understood. Well, fortunately for this patient, her insurance does cover this surgery. So, oh, look at that herniation that came out of the epidural space. Huge. Again, if you look at her MRI, these things are squashing her spinal cord, and now they're coming out, and she's going to be decompressed, which is nice. Any more questions? Okay, here's a huge tear in the back of the disc, and you can see where the herniation went out through that tear. It's in the posterior ligament. A lot of scar tissue right here. You see the gold color? That's not normal. All this is here because her herniation. These are probably the bigger herniations, 2, 3, and 3, 4. The earlier ones were smaller and not as bad, but these are really bad. Let's flip it. Look at this herniation right on top of the spinal cord right here. So it went right through the PLL. You can see the end plate right here. That's the back of the C3. A lot of herniation here. All right. There's still some herniation right here. There's herniation here. All these are pieces of disc herniation, and they're all individual, meaning that they were separate events. A lot of scar tissue right here on the spinal cord.
I'm back.
Thanks, Henry. More herniation right there. All of this was pushing on her spinal cord, causing her spinal cord to not work properly. And now that we're removing it, she'll be well decompressed. Again, look at all those pieces coming out of the epidural space. Right there, there's another one. You guys see? They just happen so fast. They pop out. We call it a reverse herniation. There's so many of them. We're almost done. Next, I'm going to try the 2-3 level. Okay, hopefully we'll get in there. I told her there's a chance. Oh, look at that piece coming right there. You guys see it? It just came right out. It was literally sitting on top of the spinal cord. I think we've gotten just about everything. Still a lot of scar tissue right here from the inflammation. Now the inflammation gets on the spinal cord too, and it causes inflammation on the dura, or covering of the spinal cord. Okay? And that can cause spinal cord dysfunction, like myelitis, inflammation of the spinal cord. Here's more herniation. Just about done. You can see a little bone spur there, but it's not pushing on anything. I'm not going to take it out. We don't treat bone spurs that aren't causing spinal cord or nerve compression. That one's far enough away that trying to treat it is unnecessary. All right. Looking good. I don't see any more herniations. Maybe a little bit right here. All right, it looks like there's some here. It's very scarred, very collagenized, we call it. A lot of scar tissue. All this stuff is not normal. It's right on the spinal cord. We got to be very careful here. Looking good. I don't see anything else, but let's just take one more look just to be 100% sure. It looks like there's something right there. A little bit of herniation, perhaps. Yeah, just a little bit. All right, we have one more disc to do, and then we'll be done. How is she doing? Stable? No issues? Do we have any issues with her? We haven't done general with her, have we? We've done 3. We've treated her lower back, correct? Yeah. We've treated her. Yeah. We did her facets, SI and piriformis. We did everything with MAC, propofol. This is her first general case. Now you used fiber optic, right? Or what is it, glide scope? Good. Yeah. I'm surprised how much stenosis there is up here. It looks worse than the MRI. I wonder if she herniated more since the MRI, because she had big tears And there's a lot of herniation here. To me, it's worse than what the MRI showed.
I just did a real gentle integration, no extension.
Perfect. All right, we're done.
All right, two off, please. Thank you.
Let's put some antibiotics. Any questions, Henry?
No current questions, but we do have a comment from Dissemination once more on YouTube saying, if anyone I know needs a service that you provide, I will recommend them to you.
I appreciate that. Thank you. We just try to do things better for the patient, less invasive, safer. We've done this surgery now 1,900 patients in 17 years. And it's a very safe surgery. Of course, there's risk with any surgery, right? Things can go wrong, unexpected, but invasive surgery like fusions, artificial discs have a higher complication rate. You can see the herniated disc pieces. There's some of them right here, just laying out here. We didn't collect them all, but you can see them, right?
Yes, we can.
That's what they typically look like, by the way. Is that my shot right there? All right. Very good. We're going to try to get up to the last disc, the number 2-3. Did you want these pieces of herniation? Sometimes we'll send them off to the pathologist so they can just make sure there's nothing unusual. All right, at this point I'm going to take the tube out, shot, and I'm going to leave the dilator. Just have to be real careful, shot. Oh, see that, the dilator. Her disc is very unusual. Things just slide. Shot. Maybe that's the difference with connective tissue disorder. Shot. Is that it's very slippery. Shot. All right. I'm going to come out of the disc and I'm going to move north. And I see there's some room there till the chin, so I think we're okay. Here we go. Now you're fine. Just hold her still in line. That's fine. Right there. I'm out. Let's check and make sure we're okay. Shot. AP, let's go. AP, Jordan. Shot. You know, Jordan, you can actually move the fluoro in two directions at the same time. As you're bringing this up, you could be sliding it. You don't have to do one then the other. If you feel comfortable doing that. All right, I'm going to slide north. Shot. All right, I need to see where we are. I feel like I'm off on the side a little bit. Let's get an AP. I am off on the side, so I'm going to bring it back to the middle. Shot. And I told her there's a good chance I won't be able to do this disc, but I think right now, the way things are looking, don't move her at all. She's very slippery. I can move this just a little bit further north. Shot. I think we can do this, folks. I really do. We're right on top of that disc. So let's get another AP just to make sure we're in the middle. Nobody move anything. You guys are doing great. All right, that looks good to me. Let's go ahead. Let's advance. Does look like she has some abnormal segmentation there with her bones. All right, I think I'm a little bit lower than I want to be. I want to go up just a smidgen. Shot. Right there. Let's get another AP just to verify we're in the middle. Again, 2-3 is very unusual that anybody would have a herniation here, but because of her connective tissue, that's good. She has a connective tissue disorder. I think that's contributing to her problem here. Shot. All right, looking good. Almost there. Shot. Yes, that's looking really good. Shot. Let's get an AP and just verify we're still in the middle. You want to make sure you're not off to the side and that you're going down the middle of the disc. That looks really good. Shot. Shot. All right. Again, we want to be really careful. I'm holding this thing carefully. That's the back. We have to have the dilator back there, otherwise you cannot safely get into the disc. Shot. At this point, we are putting our tube in, and we're right up against the spine once again. So we just got to be really careful. Shot. Let me hold this. Shot. I'm doing just little taps. Shot. Shot. Keep an eye on that. Shot. Nobody move. Dilator's coming back. Shot. I think that's good right there. Yep. Just trying to get about a millimeter or two at a time. All right, I got to go in a little bit with the dilator. Shot. Shot. That's good. It's about as far as I want to go. That's it. We're done with that. So that's as far as I can go. I could probably reach back there, but there's, again, a big herniation pushing on our spinal cord here. So we should be able to get it with where we are. All right, we're going to be done in 10 minutes, 15 max, so if you want to start waking her up. We've completed 3 discs. Now we're at the last one. This is the 2-3, huge herniation pushing on her spinal cord. Again, causing damage to the spinal cord. This is why we're here doing this surgery, folks. She does have pain, but she also has spinal cord and nerve damage. So we're here to get the pressure off the spinal cord and the nerve. And what's putting pressure is the herniation. Herniated discs are probably the most common cause of nerve damage in the neck and spinal cord damage. And that's what she's got. Well, I do have to say it's unusual to see a herniated disc at C2-3. C3-4, it is also unusual, but not, as unusual as C2-3. C2-3 is the most unusual. And yeah, the herniation is pretty big here. Once again, if the herniation's too big to come out by itself on the tube, I'm going to have to cut it into little pieces. We're inside the tube, so it's safe to do that. More herniation. A lot of big pieces of herniation here. And they're white because we did not inject the blue dye, did we? So these are normally staining blue with our blue dye, but we didn't do the blue dye. She's been under anesthesia for a while. We want to wake her up and get this thing done. So don't really need the blue dye all the time. It just helps visualize. But her herniations are so big that you can see them without the blue dye. So it's not essential to have. At least not for me. All right, we're going to switch to the other side. Sorry, Luis. Huh?
The 5
What do I need to do? All right. Again, a lot of herniation right here. People think a herniated disc there. Look at that. Look at that giant piece. Look how smooth it is. It just came out. It was sitting on her spinal cord. I'm going to cut this in half, or at least make it smaller so I can get it out.
We have a couple questions.
Sure.
This question comes from Jerry on Facebook.
Hi, Jerry.
They said, "Hi Doc, Jerry from Vietnam. Any issues with the scarring going forward?"
Any issues with the scarring going forward? What's causing the scarring, Jerry, is the herniated disc. And once we remove the herniated disc, that should stop eliciting inflammation. So it's the scar tissue comes from inflammation. And what causes the inflammation is the herniation. This is all scar tissue. It's sitting right on top of her spinal cord. And I have to remove this off the spine, off of this area, because this is where the pressure is on the spinal cord. Now we're inside the herniation, so it gives us a little bit of an advantage. You can actually see everything quite well. But this, all of this is scar tissue. Look at it, it's golden color. Normal disc herniations, like within the first year or two, they don't turn this golden color. This indicates a lot of inflammation that's been going on for a long time. So once we remove the herniation, the source of inflammation goes away. It's kind of like popping a pimple. Once you get the bacteria out of there, the inflammation stops. This is really, really bad. And I'm peeling this away 1/10 of a millimeter at a time, for those of you wondering. I'm just working it back and forth, gently removing herniation a little bit at a time. A little bit of bone spur there. Well, I'll be honest, I was worried, are we going to be able to get to this place and do this right here? And now that we're here, I'm happy we're able to get here. She needed it done. Well, you can see how much scar tissue and calcium. This is all, the gold stuff is calcium. It's found within the old scar tissue. So when you see this, you know this has been here for many years. And man, she has got some serious pressure going on the spinal cord. Wow. Again, she has Ehlers-Danlos syndrome, which makes this a bit more challenging, but we're still getting the job done. So far, this is the 4th disc we're working on. All 4 discs have shown pressure on the spinal cord from herniations that went through the posterior longitudinal ligament. Remember what we talked about before. PLL is typically a barrier to the herniation. It actually blocks the herniation from hitting on the spinal cord, but in her case, the herniations went past the PLL, and they're literally pushing on her spinal cord. And I think that's the part that she asked me, is Ehlers-Danlos different? And I said, well, I mean, you have the same problem everybody else does, but in her case, I think that the PLL integrity is compromised because of the Ehlers-Danlos. In other words, her PLL is not as strong. That's what I'm seeing right now as I'm in here. Normally the PLL is very robust, very thick, very strong, and it acts as a barrier to anything leaving the disc and getting into the epidural space. But in her case, her PLL is not very good at all. All right, well, we got 5 minutes left. I think some of this stuff is sitting right on top of her spinal cord. We're going to have to try to get as much of it as we can safely. Thanks. I still think we have 5 minutes. Let's flip. And I'm just going back and forth, left to right. Any other question?
Yes, this next question comes from Dissemination, once more on YouTube,
A lot of bone spur. Uh-huh.
asking, does your practice use any kind of peptide therapy?
Do we use peptide therapy? The answer is no. These are bone spurs, folks. Look at that. They're literally sitting at the back of the disc. And we just literally clean them out. Wow, that's unusual. This is very unusual. I don't normally see this. Very unusual. We don't use any peptide therapy, no. I'm not sure peptide therapy is beneficial to a patient. This treatment you're watching, we've been doing it now 17 years. Look at that herniation just sitting right on top of the spinal cord. Very scarred. Very, very, very scarred. All that is scar tissue. And it's putting pressure on the spinal cord. Oh, right there. I'm just shaving it down with the laser, a little bit at a time. Trying to be as careful as I can. Right next to the spinal cord. The good news is we have the irrigation going. It's nice and cool. And it keeps all the tissues cool. But I am going to take a break and move away as I did. This is a giant bone spur. You guys see that?
Yes, we do.
So the good news is most of it's not the problem. The herniation was the problem and the scar tissue. I just don't know how much more I can safely remove. This is basically the limit of what I can do. Let's flip. I got 2 minutes left. Huh? That's fine. I've done what I can. There's still some scar tissue there, but I can't. It's sitting literally right on top of the spinal cord, and I can't mess with it. I think in time that will shrink up a little more. That's as good as I can get it, folks. As I said before, there's no way to get 100% of the herniation. The best we can do is usually 60 or 70%, best case. I try to at least get 50%. With 50%, I think you get really good symptom relief. We've lost about 2 cc's of blood loss at most, probably less than that, but I'll just call it 2 milliliters. So virtually no bleeding. The bleeding that we have comes from the bone spurs that were being lasered away. As I said, the incisions, there's 2 of them. They're 4 millimeters each. They're tiny. And this is a relatively bloodless surgery compared to open surgery. She'll have a little sore throat, maybe for a day or 2 from the tube being down and from us mashing on things a little, but that will get better. She'll have neck pain from the surgery. She may have some numbness, tingling, because we've just worked right on top of the spinal cord, but that should get better and go away. She will wear a collar for 6 weeks, to prevent reherniation. Remember, we cleaned the back there, but we didn't sew it up or anything like that. The wound is dry. She's got a little drop of venous blood, not even a full drop. Typically, we'll put pressure because there's no arterial bleeding, but there's little veins under the skin that sometimes will get nicked. You can't avoid them. It happens in all surgeries. But you can see there's virtually no bleeding. There's no drainage at all. Her neck looks really good. So we'll just put pressure for a minute, and then we'll get a bandage on. We're going to put steri strips. Scope was 7. Thanks, everybody. Good job. Did she have any issues with bladder before surgery from the last ones? Do you remember? She didn't need to be cathed or anything, right? All right, Henry, you can go ahead and if there's no questions, we can end the broadcast.
Copy that.